welcome everybody from Cafe. I'm Rachel Nethery. I'm a Cafe team member. For anybody who doesn't know, Cafe is the BU and Harvard Climate and Health Research Coordinating Center. And today's seminar is part of our State of the Science seminar series, where we're inviting experts from around the globe to talk about what's known about relationships between climate exposures and health within a particular domain, and to identify sort of remaining research gaps that we need to work on. And so today we're going to be discussing the state of the science at the intersection of aging, health, and climate. And we're fortunate to have two fantastic experts here that are going to tell us about this topic, Dr. Deborah Balk and Dr. Lori Hunter. So I'll give a brief intro and then turn it over to them. So Dr. Deborah Balk is the director of the City University of New York Institute for Demographic Research and professor of public affairs at the School of Public Health at the City University of New York, and in the Marxe School of Public Health and International Affairs at Baruch College. She's an expert on population-climate interactions, and she's used a spatial demographic lens to study a wide range of demographic and health outcomes, poverty, and vulnerability. Dr. Lori Hunter is the director of the Institute of Behavioral Science at the University of Colorado Boulder, as well as a professor of sociology. Dr. Hunter has two primary areas of research. First, she examines migration as related to environmental context, with a focus on rural South Africa and Mexico. She also examines trends in rural America as related to well-being, including health and migration impacts of extreme events on the rural elderly. Welcome, Dr. Balk and Dr. Hunter, and thank you so much for being with us today. I'm going to let you all take it away. To the audience, you should see a chat at the bottom of your Zoom screen. Feel free to put questions in the chat as the speakers are talking. And we'll have some time at the end for the speakers to hopefully address some of the questions that are put in the chat. And for anything that we don't have time to address today, the speakers have generously offered to save the chat and respond to your questions in another way. So thank you again, Dr. Hunter, Dr. Balk. Really excited to have you, and please take it away. Your slides look good.
Excellent, thank you. I'm going to start us off. Lori and I are going to share the presentation, so we're going to go back and forth. And we're really delighted to be here with you. So today we're going to present a framework and some evidence for that framework on the intersections of aging, climate, and health. In addition to the framework, we're going to also give you a few empirical examples. And we're also going to tell you about CASH, which is it's a virtual center for aging, climate, and health, and you'll learn more about it during the course of this presentation. So you'll get a mix of organizational and research topics. Lori and I had the privilege of writing a framework paper with our colleague, a doctoral student in the School of Public Health at CUNY, Jenna Topoldo, and which was a framework to bring together aging, health, and health vulnerabilities in a changing climate. The URL is there for anybody, and we're going to review. This will be the basis for some of the content that we review. This was published, 6 months ago or so. So please have a look there. Just to set some context, we have the population of the world is aging. It's aging everywhere, and we'll talk a little bit about that. Life expectancy is for both men and women together is 73 and a little bit years now, but this is a more than 8-year increase since before 2000, and we expect it to continue to increase. And we expect to see even high gains in places like Asia, and then probably lesser additional gains in places that already have pretty high life expectancy, Europe, North America, and so forth. But this is a phenomena that is everywhere. Another way of thinking about these gains to life expectancy, some of which are gained by increases in improvements to early life mortality, like reductions in mortality in early life, but also throughout the life course, is to think about the population over 60 or 65. Here we see an image of the global population ages 60 and over. In 1990, there was 500 million. Roughly around now, there's somewhat more than a billion. We expect that to double again by mid-century, and by the end of the century to be over 3 billion people over age 60. switching to what we use in the U.S. In the U.S., we use the standard of 65 to talk about older adults for the most part, not uniformly. Plenty of localities actually use 60 for thinking about aging services and so forth, or older adult services. But this takes a global view, and we see the different colors represent the continents. And here we see in the last 20 years, increases in the proportion over age 65. Blue at the top being Europe, and having a pretty steep, incline, and a pretty flat incline for Africa at the bottom. We can take this out. This is projected by the United Nations Population Division out to the end of the century, 2100. This is where climate projections also go. And we see all continents increasing. And the slopes, while North America catches up with Europe, but we also see big gains in other continents as well, the Caribbean and Central America, South America, those are the next two lines, and in Asia. And I just want to point out that these are not uniform blocks. These are very heterogeneous areas. Some countries in Asia have already, like China, South Korea, for example, are well on their way to transitions to kind of aging societies. So whereas others, Southeast Asia, other parts of West Asia still have much younger populations. So again, this could have showed what, just before I talked about these population pyramids that we see in front of us. Yeah, we see that we could have also shown these gains in life expectancy. So these are multiple ways of viewing this. One way, this is a nice way to view it, partly because it helps us understand where, like points of vulnerability might begin. Of course, some countries, for example, use retirement ages that are much younger than 65. That's another way that another lens that people also have. So again, this is maybe an underestimate of focal points that one might consider at what is aging might be more locally determined. Demographers, for those of you who are not demographers in the room, we have population pyramids are a very simple tool that we use. And so you can see 1960 with a nice triangle, and 100 years later, what we call a stable population, pretty much just for the United States. Every different bar there represents a 5-year age block. And we can see, in addition to the large increase in population sizes, that's what makes the one go from a more narrow triangle to a wider kind of constant, that we've just grown in population altogether. But the share of children is declining. That is important because there are services that are provided to children. So this is as they're not only is the share declining, it's becoming smaller than other age groups. In the middle, we see that the share and a very even distribution of working age populations in the middle of in this middle block. This is important. These are people who tend to contribute to things like old age security benefits, like Social Security in the United States, for example. So we want to be able to have a good basis for understanding what size and structure of that population is, because that's how we go on. And then finally, we very much see the share of older adults, and especially women, in the oldest ages. And in fact, this is truncated at 85. But you can do this for if going mid-century and onward, we might want to look at 5-year age groups past 85, because there will be lots of people in that age group. Associated with these changes, partly just before we move to the next slide, one thing that's really important here is that as we see the share of children declining in this population, this means that we also know there are things we know about fertility that's happening, and fewer people are not having children. And associated with that is that more people in older life are kinless. And so that might have they may have fictive kin and important social networks that behave like kin, but the absence of kin may have some implication for how isolation, loneliness, things that we, as well as co-residence and other things that might matter for the care of older adults. So those population pyramids showed the entire population. This takes an individual view, and when we talk to our colleagues, ourselves in the who take a life course perspective, really remind us, and we remind ourselves all the time, that aging starts at birth. So that is all this slide is really, that your child health matters. And again, as I mentioned a few minutes ago, the gains that we have to life expectancy largely happen because we're making improvements in infant mortality. And so, exposures that we have early in life get carried throughout the life course, whether that might be exposure to an environmental toxin, to a stress, to heat, so these things we anticipate the cumulative effects to take to observe them over the life course. So aging is not just what happens once you get to 65. Here we're going to talk about the intersection, not just climate and health, or climate and aging, or aging and health, which I think is those are the sort of, those dyads are the domains where we've made a lot of progress. And here we aim to push forward another, an agenda that really looks at the nexus of these three. So the knowledge has been siloed, we would argue, we do in this paper, that like in the climate health domain, we've seen a tremendous amount of research on heat, which is really, really excellent. Very often, there's been with some attention to understanding biophysical things like thermoregulation, for example. Also, infectious disease is another area where we understand the relationship between climate and health. We've understood, the new vectors like Lyme disease and dengue fever and other things that we expect to rise with changes in the climate, for example, and their implication on health. The studies that tend to get used in this are attribution studies. They look at burden and health costs. They look at single events, and they tend to look at disasters. And so those are all great starting points, but we're going to argue for something more. In the intersection between aging and climate, we see a lot of biophysical vulnerabilities, some attention to air quality, and again, temperature. Some of the study types tend to be physiological or calometric, paying attention to calories. Sorry, that's tripping me up there. And of course, a lot with future projections of future temperature increases. And this is has been an important, there's been a lot of research recently looking at different shared socioeconomic pathways on the likelihood of future heat and future aging populations. And that will help set the stage for additional studies that can be done in that domain. And then at the nexus of health and aging, as I just highlighted a few of the global trends in aging, we have a pretty good understanding of those, at least at a national level, not at necessarily a heat zone level. We understand something about chronic conditions and sociocultural variation, very important, and bringing it on, and we'll talk about this a little bit more on climate justice lenses that can be brought to the table to help understand who's most impacted. And here again, we see a lot of physiological studies, as well as quite a bit of sociodemographic work has been done in this domain. So, but we would argue that the older adult, just looking at older adults rather than and in the life course, but these climate health vulnerabilities, they span many dimensions. They span the biophysical, they span the socioeconomic, cultural, and there are really important equity aspects that have to be attended to from the get-go. They can accumulate throughout the life course. So the focus here has been 65 plus, but we're arguing that there are lots of, that we have to do a better job of paying attention to life course and cumulative processes. So there are knowledge gaps, like in fact, much of the literature on climate health it omits older adults as well. So that's like an area where we really, older adults, and then of course variation among older adults. Much less is understood about mechanisms, less on why and how exposure matters than the fact that a mechanism might be operating, but or a conjecture that mechanisms may be underneath it. Often we observe the associations and we don't observe the mechanisms that would be causally, attributable. Again, the frameworks have really focused on those two-way dyads here. Few focus on the three-way intersection, and Lori's going to cover a bunch of additional frameworks. And finally, the data, there have been some real mismatch in the scale within the kind of data sets required to bring to bear this intersection between climate, aging, and health. So scale mismatches both in temporal and spatial scales. And we'll get a little bit to that later. So, and then lastly, we spent a lot of time retrofitting our either our health or social science data in order to make them fit with climate data. And the more we do this work, the more we recognize how important it is to try to be proactive and create data sets that are effective in observing these, we don't, that are making observations either in real time or that are purposefully fit to the kinds of data sets we need to use. With that, I'm going to turn it over to Lori, who's going to start to walk you through this, our framework.
Thank you, Deborah. You can get some water now. That's good timing. All right. Thank you so much, Deborah. And thank you again for everybody for being here. So this is a framework that we presented in the paper that we're using to structure this presentation. So climate on the left-hand side, health outcomes on the right-hand side. And we talk about the different clusters of mechanisms. And I will review each of these in a moment with different kinds of empirical examples. But biophysical, Deborah mentioned, sociodemographic, contextual, and cultural. So this is, again, the structure that we use for the presentation and the paper in thinking through the various in-betweens, right, in terms of vulnerabilities and mechanisms of impact. So in terms of biophysical mechanisms, thermoregulation is one. Thermoregulation is our body's ability to regulate temperature, and it's a natural part of the aging process that our ability to thermoregulate declines as we age. Sweating capacity reduces, skin blood flow reduces, lessens our ability to dissipate temperature. This can result in reduced thirst, which results in dehydration. So a lot of implications in terms of health vulnerabilities of older adults. In the US, between 2004 and 2018, nearly 3/4 of the heat-related deaths occurred in adults aged 45 plus. 40% of those were in 65 plus, and that's in part a consequence of these biophysical changes. One example is of empirical research is this. So we've really tried to pull out some the more contemporary research even in the last couple years as we could. This is one that looked at thermoregulatory responses and differences across age and sex, and they found that young women were those with the strongest thermoregulatory capacity. So empirical evidence of this changing across age. Another biophysical mechanism has to do with chronic conditions, which are oftentimes more prevalent in the context of older adults. At least these chronic conditions mean something that's lasted for at least a year, may require medical intervention and or impact your ability to do the activities of daily living. 90% of US residents, some estimates suggest over age 60 have at least one. That's pretty incredible. 79% two or more. So certainly prevalent, and we have to think about it in the context of climate vulnerability. One of these is cognitive health. Nearly 8% of individuals over age 65 have Alzheimer's disease or related dementia, ADRD. The level increases to over 27% when you consider those over 85 plus. This contrasts with about 2% for those younger than 65 years. So definitely something to consider in terms of older adults. One study, this one is just from earlier this year, extreme heat and hospitalization among older persons with ADRD found a 2% increase in hospitalization after 1 year of heat extra that included an extreme heat exposure, 2% with over 4 years, 4% over 4 years. But I think what's most important about this study is it actually showed that for racial and ethnic minorities, those were, hospitalization rates were 2 to 3 times higher than for whites. So a really important dimension in terms of equity. So behavior of ADRD patients can also be impacted by heat, can cause agitation and anxiety, which has real impacts for caregivers. And there are several studies that look at this. So Deborah mentioned some of the other frameworks that we'll cover here. I'll talk about this one for assessing the effects of climate change on dementia risk in a few minutes. Another one is diabetes, another chronic condition that often impacts older adults. third leading cause of death worldwide, and includes many comorbidities that also intensify climate vulnerability. So dehydration would be one, functional disabilities would be another. Here's an example from 2023 of a review on the connection between climate and diabetes. I should have mentioned earlier on, we are going to share the slides. There's a lot of references in here that might be of interest to you. So you will have those access to those after the talk. Research has shown that climate extremes or extreme events have impacted diabetes self-management and outcomes. One example is the impact of Hurricane Matthew. It was just back in 2005, but I like this study because it's qualitative and it presents the narratives of both caregivers and patients in terms of how the hurricane impacted their management. Patients talked about challenges with insulin in the context of power outages because of refrigeration limitations. Caregivers talked about the lack of sufficient or comprehensive emergency plans that included taking insulin in the case of an evacuation. So a couple of examples there. Let's talk about kidney disease and cardiovascular disease. Kidney disease is the eighth leading cause of death worldwide for those 50 to 74 years. So it's obviously very prevalent amongst older adults. Hurricane Sandy is this is one study. There are so many actually, so just pulled out a few that were, I thought, particularly of interest. Hurricane Sandy, now this study talked a lot about power outages and the impact on treatments, for example, dialysis. There was another study in Hurricane Katrina that found that 44% of diabetes patients missed at least one dialysis session as a consequence of the hurricane. 17% missed 3 or more. So think about the implications there for disease management. In terms of cardiovascular disease, now this is the leading cause of death for persons age 65 plus. The heat waves back in the 90s in Chicago showed that the risk of cardiovascular mortality was 4 to 7 times greater for older adults in the context of heat. And there has been a lot of scholarship on heat and cardiovascular risk. So a different kind of biophysical limitation is hearing loss. And in 2019, it was estimated that 1 in 5 had hearing loss globally, with nearly 2/3 of these being over 50 years. So you can think about the ways in which hearing loss really impacts the ability to understand and receive the communications about evacuation or other kinds of action plans. So this is a recent study, again from 2024, that looked at vulnerable people in a climate-related disaster, a case study of people with hearing loss facing wildfires. So another really important connection. Hearing loss, we know, also influences your social connections and social integration, and social connections or networks are a pathway through which information is received as well, including in the context of climate extremes. So it can impact things that way as well. The last biophysical is physical injuries or falls, with increased frailty of older adults. In the US, 33% of adults 65 to 74 and 50% 75 plus report difficulty walking or climbing steps. So imagine how that impacts one's ability to evacuate or simply manage the challenges of something like an extreme event. It also influences preparedness. Some really interesting studies. There's not a lot on this, but individuals who are more physically frail are actually less likely to be well prepared for the disaster before it comes. So not just when the disaster occurs or dealing with the disaster afterwards, but impacting preparedness, which is another really important and sort of not well considered connection. Let me move next to sociodemographic mechanisms. Poverty is one. The US Census in 2022 had the poverty rate of people over 65 at about 11%. That was up from 10.3% in 2021. The second year in a row it had increased. So obviously that has very important implications for preparedness, response, and so on. So race, ethnicity, and gender as well intersect in terms of sociodemographic mechanisms and climate-related vulnerability. This is a study, I'm sorry, from a group of colleagues of mine that work at the Natural Hazards Center. They looked at mortality from forces of nature by race, ethnicity, and gender, and found that so this is males are the dotted line, females are the dashed line, whites on the left, blacks on the right. You can see that mortality by gender was very pretty equal for whites, but quite distinct for blacks, different levels across different ages as well. And then migration status matters too. So think about being new to a culture and or a society and not having information on healthcare availability and access. And then also there are studies on linguistic isolation as well. So I've talked about these two. This is just a little bit of a roadmap. I'm very quickly going to go the next two, paying attention to time. So cultural mechanisms include the social isolation that characterizes many older adults, sadly. Living alone. So a quarter of adults age 65 plus live alone. Over half reported feeling isolated. So those who receive support from family, friends, and neighbors are much less likely to experience mortality in the context of heat. Risk perception matters too. So older adult studies have shown are less likely to perceive the accurate level of risk that might be facing them. And then, of course, that results in not engaging in recommended behavioral change. A study of 4 North American cities found amongst those 65 plus, 90% of respondents knew about a heat warning in the context of a heat wave, but less than half of them modified their behaviors at all in response. Contextual dimensions, quickly, urban and rural, a tremendous amount of hospital closures in rural areas. Over 200 rural hospitals have closed since 2005. 700 more are at risk of closing soon. Residents have to travel on average 20 miles more to receive health care. And that might not seem a lot, but imagine what that 20 miles means in the context of an extreme event. So those are our 4 mechanisms, gave you some empirical examples, a couple of other frameworks. This is one that was put forward just last year on healthy aging. So just so you know that there are other ideas about there that might be of use to you as you consider your own empirical work, healthy aging being their outcome. Some of the mechanisms that we use are over here on the left-hand side, thinking about climate change. It's really interesting to sort of work through this in your head and certainly helpful as you design studies. And this is the one I mentioned about dementia risk and burden. So they have as their outcome ADRD, looking at the mechanisms like we do, many of them are the same, and then climate pressures at the top. So those are some examples of this 3-way intersection, and I will now pass it back to Deborah to talk about cash.
Thanks, Lori. So with this extremely large sort of research agenda, yet that Lori just introduced us all to, many of us come to it from one perspective or another, right? We come to it from our own discipline, we come to it from our own interests. And at CASH, and most of us are at institutions that have one, that we're in a department of X, Y, or Z. And so trying to do interdisciplinary work has always been a challenge. So the idea behind CASH is to reduce the burden, the barriers to entry into this very interdisciplinary field. We're all interested in the interdisciplinary questions. So and so this was an effort to try to reduce those barriers and to do it with a collection of institutions rather than one institution at a time. Many of us have, our institutions are really strong in one domain, but not in another domain, and so on and so forth. So this is a joint effort by 5 institutions. We focus on climate health, impacts of older adults, and life course perspectives. And we have this targeted interdisciplinary training and funding opportunities. I put a link in the chat for some, and I'll talk about it in a moment, for some of those training and funding opportunities. We have a hub of information for code sharing and community building, and we try to facilitate research and collaboration through these network activities. So we've had a lot of virtual seminars, one in February on social and environmental data integration at the US county scale, one just on measuring extreme temperatures. And I encourage you to come to these seminars. I mean, these are not like the seminar we're giving today. Like, we really get under the hood and talk about why we chose a particular temperature measure, for example. And so we have these, you can watch the videos of them if you're interested. We had one last month on climate systems, and we have one tomorrow. Please come on climate risks with an application to health. So these are, and we had the one in May and the one tomorrow are being given by climate scientists to help, like, again, explain, and there's opportunity in those to ask questions as well. And so please join us. In addition to that, we have a section for data and codes. We held a workshop on how to use the SHIELDUS, which is the Spatial Hazards, Events, and Losses database for the United States, linking it with American Community Survey microdata, the individual level data. That workshop has an R Markdown system that you can download the entire thing. It has in it, like, way to go grab the data that you might need for this. And so you can find that also on our website. And data and code, I'll say more about that in another. That is just one example. There are others and more coming, and we invite you to bring your examples to the table. We also have a small blog-like thing called One Am I Reading? There's one on the frameworks written by Jenna Topaldo, and recently another one on pollution, cognitive aging, and how we measure the hard to measure by Elizabeth Sorensen. So, and again, if you're out there and you would like to contribute one of these, they're short form. They're just more isolated to a couple papers on a topic of interest that if you have a new paper and you want to put it in context, we invite that too. So all please reach out to us. So let's talk for a moment about seed grants. So about our opportunities. One of them is seed grants. You can find in the link that I put in the chat. We have these pilot project seed grants that are 20K for data integration. We're encouraging people who are new to the intersection of climate, aging, and health, like in particular, the intersection of those three. The call is due at the end of this, or maybe June 20th, if I'm correct on that. And then the funding for those will be distributed in probably around September 1st. We aim to make awards available. So. And then similarly, we are encouraging everybody to contribute code so it's easier for the next person, or imagine yourself having taken like a code example, and we make data available. So again, the coding is, we have just a small stipend for somebody to put together and if you've already made the code available and you want to, there's also a way to, like on GitHub or something like that, you could, we have a little coding template that standardizes what you want to explain about the code for a novice user and its more general applications. So those are both available there. And again, you can see the link in the website that in the chat that I put. There's also, I'll put a link now also in for, and Lori, I can go to the next slide, for the newsletters, I believe are here. So you can also find our newsletters there. As part of this, we have these demonstration projects that we split across the founding institutions. They form the foundation of the development for the early material and hope that others will come to the table. And they also aim to act as examples of broader usages. So here's an example. There are 6 of them. I'll walk through them just so you get a flavor of them. One that I'm going to describe in a few minutes looks at a very vulnerable population, people who are buried in public burial grounds. This case is New York City. It uses a variety of weather data on extreme weather, and it's individual level data by geocoded, and it goes over geocoded temperature data over a very long period of time. A second study uses the ATUS, the American Time Use Survey, and connects it with information on heat. That linkage is at either the city or county level. And again, it goes over roughly a 20-year period for the entire US. We next have a project that Lori's going to describe on disasters and the health of rural elderly. So the focus here is using national level data sets, but with a focus on understanding rural populations, and they use publicly available data, but in a restricted data enclave. And so that's another many of our of the data sets that form like the fabric of what we understand about older adults are, they're publicly available versions of them, And they're like the health and retirement survey, for example, which we see next, but they also have, for if you're going to use the geocodes, you have to do it in a restricted data enclave. So Lori's going to tell us a little bit about her restricted data enclave project. So that project is in the US, the linkage is at county level, but the county data are not available in the publicly available data. So, and then the next one is on neighborhoods, cognitive aging, and climate among aging Americans, and that uses a health and retirement survey. Both of these use SHIELDUS, which is the hazards database. And then the last two data sets, one is the last two demo projects. One what it takes is a global project looking at the global burden of disease data, and it matches it with a different temperature and precip data sets, CHIRPS, and also some air quality data, and it's more subnational in nature. And then the last one is on living arrangements of the elderly and care patterns and heat stress. And this is another, again, like the first one, which was New York City focused, this is Mexico City focused. And the idea here is that these projects together find they have a range of temporal and spatial resolutions. They have a variety of social and health data sets, and they have a variety of climate, environmental, or disaster data sets that allow us to speak to a much wider range of examples. Okay, for a moment, I'm going to switch and tell you about the one I'm engaged with here with colleagues. It's very interdisciplinary. It involves myself. I'm a demographer, my colleagues who are economists, public health specialists, geographers, and climate scientists. The background for this project is that we were looking at public burials in general in the wake of the COVID epidemic. And many of you might have, when COVID first came to when the COVID epidemic began, many people were buried on Hart Island. Hart Island is the nation's longest public burial site, extending hundreds, more than hundreds of years actually. So it's been around for a long time, and so there are more than 1 million people interred there. And what we were, but we were using it, and then we added on this dimension to look at temperature. So the people who end up at Hart Island, buried at Hart Island, are unclaimed. Sometimes these public burial deaths are called unclaimed deaths. This means that after an attempt to notify kin, no one has claimed a body, the deceased body. Therefore, people end up at Hart Island. Sometimes it's due to isolation, sometimes it's due to economic vulnerabilities. But by most measures, the majority of people who end up in public burials are considered especially vulnerable. So, so we wanted to then integrate these death data with daily air and wet bulb temperatures to see whether there is a signal on an association that we can observe in New York City to look at mortality associated with extreme temperature, both cold and hot extremes. And so we do this over a nearly 50-year period. Next slide, please, Lori. So this just gives you a sense of what these unclaimed deaths look like. The blue represents males, the orange is females. There's some years for which gender is unknown. We did an imputation on that. You can see the spike for COVID. The graph on the graph on the other side just shows the seasonality. So we actually see the winter months have higher, on average, slightly higher death events. And then the overlay shows age. And so we see the age of decedents is, I'll talk about this again at the end, but it's like, it's over 60 for women, and it's slightly under 60 for men. So not a young population. Other public burial grounds, such as, for example, in Los Angeles, have much younger individuals buried in their public burial grounds. This is temperature data, so it's that shows min and max. There's quite a bit of variability over the seasons. We use both this data and Lori, next please. This we compared both the data that we just saw are represented from New York City's 3. They're a compilation of the 3 observation stations, 2 at the New York City airports, LaGuardia and JFK, and another at Central Park. And then that gives us air temperature, but we also used a feels like temperature, this wet bulb measure, which is what's flashing on your screen, and that comes out of a model. It's gridded data, it's reanalysis data from the ERA 5. And so we use that over, and both of these are available for the long time. We take the averages. And for this particular results that I'm going to show you today are just all New York City. So we take the average of these mins and maxes. There are some advantages to the different kinds of data. They're here. In the interest of time, I won't go through them. I'm happy to talk about them more. This is the kind of thing that we do at CASH. We try to talk about the differences and why these differences might matter. But just to give you a flavor of the results, we find a very strong estimated effect. In the summer, roughly a 1 degree Fahrenheit increase in the 7-day maximum temperature is associated with the increase in number of daily deaths unclaimed by 1.2%. The 3 and 7-day lags both show stronger mortality relationships than the 1-day lags, which is an interesting thing. And then we also, for the other seasons, we find, we can go to the next slide. We find that the relationship with the other seasons and also just with minimum temperatures, so what I'm showing here is max, they're weaker and they're less consistent. So we find a very strong summer signal indicated by that bright red upward slope there. The others are both more, but there is a little bit of activity going on. So it, we were glad to have tried to unpack that a little bit. So with age in particular, since this was, focused by trying to see if we can unpack age, it turns out that there's both everybody buried on heart. There is a signal regardless of whether you're over 65 or under 65. So, but the average age of death in this population for males is just under 60, and for women, it's older. It's 66 and a half. So, and public burial is possibly a proxy for mechanism. We don't have any direct observation of mechanism in this data set. We receive these data sets after somebody's died. We don't know a lot about these individuals in life, unfortunately. So, but we do, the research on public burials tells us that these individuals are most likely, they experience poverty and they may experience isolation. So those would be the kind of mechanisms we would want to look at next. And then lastly, what we did was for this long period of time, and we averaged the data set, but the public burial data indicate place of death. And therefore the next stage is to look at variation within New York, and not just to look at air temperature, but to try to create a model that lets us look at, that takes into account what could be indoor air temperatures as well, because many people many people may be energy insecure, and the built environment indoor temperatures would be much different and could be a leading cause of either cold or heat deaths. I think, just to say with the general application before I turn this over to Lori, is that public burial data are like any other administrative data. They're vital, like vital events, hospital records, and so forth. This is a temporal study over the long period, so we paid attention to a whole bunch of things in our modeling that we can generalize for long-term studies, and it's city specific. And with the world's population increasingly being urban, that's another thing to pay attention. And in fact, a lot of the climate data are not so, excellent for intra-urban analysis. So that's where our next steps are. But rural areas are also important, and we're going to hear about them now from Lori.
Thank you, Deborah. Really appreciate it. So just before I start, well, I'm also going to say I'm going to zip through this in a couple of minutes, so we have some time for Q&A. But just to remind you that we're showing you these two examples just to illustrate the kinds of work that, as Deborah explained, we want to help get under the hood. We want to help people know where these data are, know what kinds of measures are available, and provide the code that would allow for integration. So these are just two examples of projects that we provide information on them in order to help folks learn about integration and about measurement. So come on over to CASH and be part of the community so we can help this work move forward. So the project I'll quickly talk about in just a quick minute is on rural older adults' health and extreme events. We were interested in the moderating factors of social support, healthcare, and health insurance because those vary across rural and urban spaces. We wanted to see how they differentially impact older adult health as related to extremes. We use the National Health Interview Survey. We use rural urban codes that are from the USDA and the Social Vulnerability Vulnerability Index. We use disaster declaration data from FEMA. And as Deborah mentioned, we use Shieldus, which is a loss database out of Arizona State. We also have measures of weather, just temperature, so that we can see anomalies as compared to the last 30 years. We integrate these at the county scale. We run propensity score models and regressions. Quickly, the NHAS has several measures of both physical and mental health, and we're using both of those. We are undertaking these analyses in the RDC, and that's also something that we grapple with in CASH to help folks understand. But while you can get public data from the NHIS, the National Health Interview Survey, those data don't include county indicators, so you can't attach the environmental data to people in that. In order to do that, you have to propose that analysis. It has to be accepted by the agency, and then you work within an enclave. We're making this integration code soon available via cache, and it's the kind of code that you might be able to use for any project where you want to integrate data at the county scale for the US. So again, county-specific integration. We work with the disaster data in this restricted data enclave. It's hard. It takes a while to get these proposals approved. It takes a while to get access to the data, so you really have to build that into your process. But we are particularly paying attention to analytical issues for rural areas. Rural individuals are often underrepresented because their numbers are smaller. So in national scale surveys, that's always a challenge. So we're dealing with that right now, and our lessons we will be putting forward through CASH. So not everybody has to learn them like we're learning them. We'll give them to you anyway. So we will end there. So we have a few minutes for questions. We've talked through a framework, given you some empirical examples, both from others and from ourselves. And we've introduced CASH, the Center for Aging, Climate, and Health. And we very much hope that you'll join us there and that we can provide some support in moving this work forward. So I think we'll stop there.
Thank you both, Deborah and Lori. This was fascinating, and I think I certainly learned a lot there, and there were so many great references. As Lori mentioned before, we'll be sharing out the slides as we share out the recording on our YouTube channels and on our website later this week, probably. So we have a couple questions coming in the chat. I'm going to start giving those to you now. Greetings from Bolivia. I work in the Pan American Health Organization country office. We are starting to work on climate change and our maternal and child health, and our next step will be aging population. So thanks for all these inputs. Can they apply as international cooperation agency to the seed fund you mentioned? Otherwise, they share with public university here that is working on this issue. Yes, a recording will be available for this webinar, and you can find any access to the previous webinars on our YouTube channel, which I will share in the chat. But for the question, can they apply as international cooperation agencies to the seed fund that you brought up?
So there are this is National Institutes of Aging funding, and you probably all know that sadly the rules and regulations around these dollars and how they can be spent are rapidly changing. So what I would ask is that you write me an email. We will look into the current status. It feels like it honestly changes every week. It may be best if international organizations apply through US based as consultants or something, but why don't you write me, lori.hunter@colorado.edu. I'll put my email in the chat, and I'll work with our finance people to get the answer as of today. So I'm sorry that it's so complicated. Let me tell you, I'm very, very sorry.
Yeah,
Yes.
I stuck the cache info that also gets to us as well. You can send us any questions about the particulars. As a general rule for these pilot projects, the one has to apply with an institution that's eligible to apply for funding from the National Institutes. So we don't take individual applications. And like students, for example, would have to apply with a member of their faculty or whomever would allow them to, since many institutions don't let students to submit grants from their institutions directly. So, and these are guidelines that we're taking from we're using the NIH stipulations, not our own. I reach out to Lori or the other email below here.
Another question. What are the urban design strategies to address increased urban heat island effect by climate change and elderly well-being?
Okay, that's a great question. So I would suggest for people might want to look at like some cities have their own climate assessments, like New York City has a New York City panel on climate change. And there are lots of issues here on walkable pathways, the use of trees and other sort of natural infrastructures, nature-based solutions that so urban design strategies are, one thing is to think about, how we use cooling, how we use the natural environment for cooling, how we make our cities less hot and how we make them, and then of course, a lot of attention just to energy efficiency, how we have more energy efficiency cities. So there's always a trade-off. Cities are hotter, but in fact, they're more efficient. So the other thing I should say is that there are some networks like UCERN is another network that's very city specific, UCCRN, that really pays attention to like an international collection of case studies of cities that people can look at for various kinds of potential design strategies. But I think more walkable pathways and walkable shaded pathways that allow for people to sort of be more healthy aging, but also protection from potentially extreme heat. So
I have a question myself, which is, what do you feel is the most urgent gap in this field? If you could determine the next thing that is solved within this tri relationship that you mentioned between aging, climate, and health, what would be like the most urgent gap that we could address?
My answer is going to be dissatisfying because it's going to be about data. But I think part of the problem in answering these questions is we don't have readily accessible, good data that allows for the integration of these. So, Deborah briefly mentioned having to retrofit some existing data sets. So I would love to see us be a little bit more thoughtful and systematic in designing some collection methods explicitly to look at this connection. That's not a substantive answer, it's a methodological answer, but I think it's really important.
Thank you for that.
yeah, can I just one of the things is I think this is a little dissatisfying, but like it's a little easier for us to pay attention to the disasters and here and now. And I think, there is work on the more medical side of being able to recognize and address in a clinical setting things that are related to extreme events. But apart from that, I think that like Lori said on data, but it's setting up infrastructure to be able to look at these long-term changes and prepare for them. And a lot of the planning horizons are very short. They're 5-10 years at most. And we're going to have what we have now is only a fraction of like what we will experience in mid-century and onward. And I think it's incumbent upon us to be really thinking about how to have the data and observational infrastructure that's actually effective in that setting. So,
and I'll add too, again, this is sort of a general answer, but it's not so hard to come up with correlational analyses, right? So you've got a descriptive analysis that says more of these people passed away than these people, or more of, hospital admissions, but getting that next layer and thinking about what are the mechanisms that have led to those disparities. Now that gets a little tougher. So I would just encourage anybody who's stepping into this space to go past descriptive and really think about pathways and mechanisms, because that's really going to help move forward understanding, because it's those pathways and mechanisms that are going to tell us where the interventions need to be, right?
That's where the actionable stuff is at.
Yeah.
So, and we really haven't done due diligence in that at all. So think mechanisms.
Those are really fantastic answers. There's a lot of rich stuff in what you just provided. So thank you. Those were not dissatisfying at all. So I'll put you at ease about that. It looks like we are about at time. Thank you both so much for joining us and for talking about cash and this really important work. This was a really fantastic webinar, and I think it will continue to be a really great resource for everyone who is able to see the recording of it. So yes, we will be sharing the recording of this webinar on our YouTube page. I'm putting the link to that in the chat now. And of course, you can find that on our website as well. And we will be sharing the slides. Thank you very much. There were a lot of really wonderful resources available in those slides. So we'll be sharing those around as well. Both Deborah and Lori shared some email addresses in the chat. So if you would like to follow up with them about their work, you can do so. And otherwise, thank you both for joining us again. And we'll see you at the next Day of the Science.
Thank you for having us.
Thank you.